Morning, Dr. Samir Basak, Dr. Chandan Pal, and dear postgraduate students. I welcome you all for this RESA DNB pain medicine session. Dr. Samir Basak is our senior consultant anesthesiologist at Cottage Hospital, Southeastern Railway, and is a gold medalist in the fellowship of IASP fellowship exam. So he's a renowned faculty and pain medicine specialist in the entire zone of Calcutta. I invite Dr. Samir Basak and I take the pleasure of introducing him to all of us.
Thank
And
you, sir.
I have requested Dr. Samir Basak to deliver his.
Sir, my screen is visible.
Yeah, visible. So I requested him to share his knowledge and experience for the benefit of our RISA colleagues and PG students. So he readily agreed. That shows his enthusiasm and passion for teaching and sharing knowledge for the welfare of the patients. So now over to Dr. Samir Basak to go ahead with the presentation.
Thank you, sir. Very good morning to all the delegates. Okay. So, this is the very new concept as created by Dr. Selvam sir to start one DNB class for the student. As they will get benefit, we will also learn as a teacher, because teaching is also part of the learning. Thank you, sir, for giving me the opportunity to speak in this DNB forum, and I am, without wasting any time, I am starting the topic. Because as we know, in our MD or DNB syllabus, this is a vast syllabus, and in our day practice, we generally practice anesthesiology and less focus on the pain or critical care. So if we want to discuss about the pain medicine, then in the third and fourth paper, this subject is so much important that almost 300 marks question in theory, also in practical there is. So myself, Dr. Samir Basak. When we go through the DNB or MD syllabus through the National Council of India, we can see there is the into out of 24-page syllabus, there is a vast content of pain medicine related chapters, what we should learn during our DNB or MD training. What are the content? When we go through the page number 2, we can see there is the regional anesthesia, field block, neuraxial block, block for acute pain state are there. When we go to the page number 9, there are the demonstration of the acute or chronic pain management. You should know how to assess a pain patient from the history to physical examination to the interpretation. Then regarding the classification of the types of pain, acute or chronic, traumatic, non-traumatic, cancer, non-cancer, with the knowledge of pain pathway in details. Next come to the physical therapy, different modes of physical therapy that may relieve both acute or chronic pain. Then acute cancer pain, all the WHO guideline, all the types of treatment. Routes of administration and risk benefit of the drug used for acute and chronic pain relief. Patient control analgesia, treat the common pain syndrome. All this we have to learn. Demonstrate the practice of pain management in patient with problem during drug use, drug dependency, addiction. Identify the parameter for referral to a pain patient specialist. When to refer, and demonstrate the organization of acute pain service, acute pain nurse for the pain assessment. When we go through the acute pain service or role of acute pain nurse in the pain assessment, there is a physiological changes secondary to pain, practice of different modality of pain control, pharmacology, opioid analgesia, non-opioid analgesia, patient control analgesia, all are in this group. Next come to the demonstrate of chronic pain and manage the chronic pain. When there is chronic pain, not only physiology and pharmacological therapy is important, but also there are psychotherapy, cognitive behavior therapy, neuroablation, or there is the neuromodulation. Already one conference fixed in Mumbai about the neuromodulation in the month of November. Next come the neuro augmentation, like there are fracture. There is fracture. We have to vertebral fracture, vertebroplasty, kyphoplasty. This kind of neuro augmentation. Spinal opioid, interventional neuroblockade, non-opioid analgesia. All are in the chronic pain. These are all in the DNB or MD syllabus, not in also pain subject. Next come the management of cancer pain, principle of management of non-cancer neuropathic pain, phantom limb pain, post-herpetic neuralgia, complex regional pain syndrome, trigeminal neuralgia, management of non-cancer nociceptive pain, myofascial pain, low back pain, intractable angina, burns, pancreatitis, and peripheral vascular disease. And regarding the anatomy indication of the different types of sympathectomy, like lumbar, stellate ganglion, celiac plexus. Next come the peripheral nerve block, practice of opioid steroid injection at the all level, not only in lumbar but also thoracic, and we do practice in cervical. So the all level there is mentioned, specifically mentioned all level. And long term epidural catheterization in case of cancer pain, we keep the catheter for long term. So observe the practice of the infraorbital intercostal nerve. These are the peripheral nerve blockade. And complication with the each block, know the appropriate treatment, know the indication of stimulation technique, transcutaneous electric stimulation. These are also non-invasive. Dorsal column stimulation, this is invasive. Deep brain stimulation done by the surgeon, invasive. Indication, these are the indication, we have to learn the indication. Then mechanism and side effect of the other therapies. Principle of management special pain patient, including children, elderly, disabled, intellectual. There are various scale to assess the pain in this kind of patients. Like in children, faces skin, there are the by looking at the different type of face, we can assess the pain. Like in elderly, ventilator patient also, we can assess the pain by different pain scale. Awareness principle of insertion and management of implantable drug delivery pump, like intrathecal pump for cancer patient. Awareness and basic principle of palliative care. So, as a when we pass our DNB or MD anesthesiology, we also become a pain physician because we have covered all these things during our training. Next come the pediatric pain management. When we should learn all the things during training, first 6 months we should learn the anatomy, physiology, then come to the basic principle of safe anesthesia, resuscitation, and prevention or treatment of pain, acute and acute pain. They are focusing on the acute pain mainly during the first 6 months. Next 18 months, we have to provide our student ample scope to block under supervision and use of the USG machines to give the different types of block with the and venous cannulations. Next come the last 12 months. Next, and the final year is the most important for the chronic pain mainly. They are student able to manage critical ill patient, treat intractable pain. These are there. So at the end of 3 years, they should able to treat post-operative patient any pain relief for elective emergency surgery and manage the pain suffering from chronic and acute intractable pain. Course the content of course, there is a syllabus also. So syllabus, there are the anatomy, physiology, physics, all in the first year. We have to cover regional anesthesia, field block, neuraxial block, block for acute brain state, all in the first year. Physiology, physics, all in the first year. Next come to the biochemistry and introduction of acute and chronic pain and pain management. This is the basics you should know in the first year only. Next, in the third year, come to the chronic pain therapy, therapy for acute nerve block. Next, come for few others physical therapy, non-invasive, semi-invasive therapy, acupuncture, acupressure, non-conventional treatment, all in the third year. Neuro-augmentation, neuromodulation, intrathecal pump, everything in the third year. And regarding the training, 1 month out of the total OT posting, 1 month is the pain. For dedicated to the pain therapy, 1 month posting. Regarding the formative assessment, we can see in the paper 3 and paper 4, there are anesthesia in relations to subspecialty or super specialty. Here in the paper 3 also come pain medicine, critical care medicine. And paper 4, they specifically mention pain medicine and decent advance in addition to critical care. So it is going to be very important topic for the DNB and MD student during training to learn the basics and few advance of the pain medicine. Regarding the book, to what book to read, there is Prithviraj and Prithviraj, Regional Anesthesia and Practice of Pain Management, both written by the Prithviraj. And there are old other Goldman, there are Waldman books is there. So Prithviraj is, if anybody wanted to know more about the pain medicine, they can go through the Prithviraj. So this is for myself. My motto is to after pass the MD anesthesiology, I dream about to become a pain physician. When I have seen my grandparents die of gastric cancer pain in the remote village without proper treatment, then I determined to do something after passing MD anesthesia, and so I joined pain medicine. And pain medicine is the branch where you can practice as a independent super specialist doctor, not as an anesthesiologist only to the independent field. If anybody wanted to join pain medicine fellowship or FNB course, they can contact me. And we are going to organize a seminar. This is a workshop, live workshop, and dedicated for all the doctors in the critical interventional. They are going to do some advance other than from the field of anesthesiology, from the field of orthopedics, from the field of rheumatology, from the field of neuromedicine. If they wanted to join, they can join. Okay. So I'm going to my next topic. This is the pain pathway. My screen is visible, sir?
Yes, visible, Samir. Please proceed.
Okay, thank you. So regarding the pain pathway, first we have to know the definition of the pain. As very recently, 2022, International Association for the Study of Pain has defined the pain, because we all over the India use the only one definition to identify the pain. Previously, this was some other thing. We have not included any. There is, if there is no cut, if there is nothing, and then how can we assess the pain? There is, as there is no visible thing. When patient complaining of low back pain, we are unable to assess if he is complaining and this is a fake or actually patient is suffering from pain. So recently, International Society has defined the pain, and all over the world we are using the same definition. And this is an unpleasant sensory emotional experience associated with or resembling that associated with, this term is included, actual or potential tissue damage. So it is an unpleasant sensory and emotional experience that is associated with or resembling that associated with actual or potential tissue damage. Tissue damage may be present or may not be present. When it comes to the pain pathway, there is first in our body, some sensation is transducted from mechanical nociceptor, from thermal nociceptor for chemical nociceptor. We receive something, then this stimulation converted into signal, pain signal. So other mechanical signal transmitted into electrical signal. All mechanical, chemical and thermal is three types of signal transmitted by the, there are the pain reception receptor. So from this transduction there is transmission in our body. This signal transmit up to our brain, then higher processing center. From the higher processing center it modulate our brain, our other system, descending pathway, all modulate our pain. Then we perceive the pain as a sensation. Sometimes we may feel, sometimes we may not feel. This is all about the modulation, how we modulate our pain. So regarding transmission, A delta and C fiber both transmit the pain signal. A delta transmit specifically sharp pain at the speed of 5 to 15 meter per second, and C fiber transmit the pain less than 2 meter. This is for slow pain, dull pain, this type of pain. When come the modulation, how we modulate our pain as we receive, finally perceive our pain. Sometime there is cut but we may not feel. This is because of the endogenous pain modulation. There is a segmental at the particular spinal segment, there are GABA mediated inhibition, other inhibition. So segmental inhibition, there is a gate control theory. When we rub our area where there is cut or something, our pain gradually decrease. This is the because of the A beta fiber mediated touch sensation or the rubbing stop the A delta mediated pain. So A beta mediated fiber stop our open the gate for the rubbing or the pressure sensation. Then our sharp pain or A beta mediated pain gradually we may not feel that time. This is the gate control theory as proposed by the Meljag and Walls in 1965. By this theory, they also got Nobel Prize. Very important gate control theory. And descending inhibitor pathway by serotonin and non-adrenergic pathway. And we are using, as we know in our day-to-day practice, that we are using gabapentin, pregabalin, all this medication act to increase the to improve the descending inhibiting pathway. So this by these four important pathway we modulate our pain signal, and endogenous pain modulation by the opioid, endogenous pain mediation. Next come to the regarding physiology, normal and abnormal physiology. When we perceive something from the peripheral nociceptor, this pain signal go through the peripheral nerve, and they are in the first order neuron ends in the dorsal horn. Then from the dorsal horn, there are the second order neuron start, is goes through the ascending pathway up to the thalamus. Then from the thalamus, third order neuron start and go up to the higher processing center. Next, from higher processing center, there is the descending pathway as the periaqueductal gray matter. This will come. How this pathway act will come now. So there is injury in the right hand, and inflamed damaged cell release the prostaglandin. There are the dorsal root ganglia. It is the cell body for the first order neuron, and from this first order neuron, spinothalamic tract and second order neuron start. And in the higher processing center, there are the somatosensory area just at the gyrus of the post-central area. Post-central gyrus, somatosensory area 1 and 2 are the higher processing center. These are the sensory homunculus. You all know sensory homunculus, our hand and face mostly cover, then other organ also then comes in the lower side. So when inflamed cell release the prostaglandin, first order neuron carry the sensation to, this is the first order neuron path, first order neuron here ends. Next come the second order neuron. It cross the contralateral side. So our this side pain received by the opposite side of the brain. So it cross the contralateral side as a way spinothalamic tract. Second order neuron go through the medulla, through the pons till the thalamus. In the thalamus start the third order neuron. It goes to the brain and we perceive, after modulation, we perceive it as a pain. And there is the substance P released by the first order neuron. It carries the pain signal to the second order neuron. When coming to the descending pathway, it starts from the periaqueductal gray matter. Next come nucleus raffimagnus at the medulla. From the midbrain periaqueductal gray to medulla nucleus raffimagnus. Then it further carry the descending signal, inhibitory signal up to the first order and second order neuron junction. That is the lamina 1 and 2. It releases the serotonin and non-adrenaline. It ends this way, and when we magnify this one, we can see it is magnified, and how here this is the most important part. This is the substantia gelatinosa. This is the lamina 2 in the rexate lamina system. Here is the substance P released from the as a vesicle granule inside the lamina. There is the second order neuron. It is stimulate second order neuron to carry the pain signal. But what happens? Always this first order neuron to second order neuron pain stimulation is not carry freely or smoothly. There come few inhibition. Descending inhibitory neuron release noradrenaline or serotonin. So what this molecule do? This do first inhibit the first order neuron to release the substance P into the synaptic cleft and stimulate serotonin and adrenaline stimulate the interneuron. There are few interneuron in substantia gelatinosa. What this interneuron does? Interneuron does the enkephalin, release the enkephalin or the opioid, endogenous opioid, and opioid do the rest of the job. Opioid do inhibit both the first order and second order neuron. So pain signal is inhibited. From our pain stimulus, pain pathway started after transmission started, and pain transmission in the substance gelatinosa in the dorsal horn is modulated, is inhibited by this way, by the serotonin noradrenaline is this way, and by endogenous opioid these are inhibited. So there are the cell body in the dorsal root ganglia. This is dorsal root ganglia, primary afferent nerve fiber. It is just outside the spinal column, and in first order neuron, glutamate is the primary neurotransmitter. Here at the lexate lamina, it is a very important part. Part 1, 2, 3, 4, 5, 6, 7, 8. And where is 10? 10 is the surrounding the central canal, spinal canal. It is the MCQ. X is in the central spinal canal, and most superficial is 1 and 2. 1, 2, 3, 4, 5. These are the important for transmitting pain signal. Other for the motor signal, motor pathway. So 1, 2, 3, 4, 5 most important in the dorsal horn as a pain when discussing the pain pathway. And there is the spinothalamic tract. This is one of the important. So sensory C fiber mainly transmitted through lamina 1 and lamina 2. It is a superficial part. Sensory C nociceptive afferent endings are distributed, and visceral afferent are the lamina X, central region of the spinal cord, lamina X, and adjacent part of the 3, 4, 5. Okay, visceral C fiber. Cutaneous A delta, mechanical nociceptor. It also end in V, lamina V mainly, and lamina 1, 3. And collateral of the large myelinated A beta fiber also lamina 5. So lamina 5 is important for the modulation, for the gate control theory, where A beta and A delta both are terminates. Here the gate control theory works, or neuromodulation, the huge neuromodulation chapter syllabus and practice dependent through the this lamina 5 wide dynamic neuron. Is the lamina 2 or the substantia gelatinosa. Mainly there are two type of neuron. One is inhibitory and other is excitatory. For excitatory there is the glutamate, for inhibitory there is the GABA, gamma amino butyric acid. They are the neurotransmitter. They are the nociceptive specific neuron in the lamina 2 superficial part. They only carry noxious stimulation, not any touch or any pressure sensation, only pain sensation. And while coming to the lamina 5, there are the wide dynamic range neuron. They concentrate in the deeper lamina. They carry the uh, pain, both the A beta and A delta and the C fiber. So in non-noxious stimulation and noxious stimulation, both are merged here. So when we feel some non-painful stimulus is painful, these are the some other pains. These are all regulated, modulated in the wide dynamic and range neuron. We term as allodynia. Allodynia is a non-painful stimulation become painful. So wide dynamic neuron is the important part. Lamina 5. Next come the ascending pathway, central ascending pathway. So spinothalamic tract, as we see, second order neuron, spinothalamic tract integration. Spinothalamic tract mainly carry the nociceptive information, cutaneous nociceptive information. Then dorsally there is the postsynaptic dorsal column. These carry the touch, pressure, and vibratory sensation. And from the visceral pain always dull pain, not like the cutaneous and sharp pain. Also visceral pain from the lamina 10 and lamina 5 goes through the postsynaptic dorsal column, PDCP. This is the postsynaptic dorsal column. Next come our when there is pain, we become alert. When we're sleeping, something bites us, we alert. So alerting response goes through the spinal-reticular pathway, autonomic response. Next come the spino-hypothalamic, spino-amygdalar, limbic, and cortical connection. These are all motivational or affective response. And when we suffer, we cry, anxiety, there is increased blood pressure, heart rate. As we see in anesthesia monitor, patient under pain increase the heart rate, increase blood pressure. By what? But what mechanism they increase? By autonomic and endocrine response. And which pathway responsible? They are the limbic system, spino-hypothalamic, cortical connection. All these are responsible for our awakeness, our attention, our increased heart rate, increased blood pressure. All these are important. Limbic system for important increased heart rate and blood pressure. So descending pathway start from the midbrain, periaqueductal gray matter. This goes to the rostral ventromedial medulla, then come to the spinal cord. Rostral ventromedial medulla is the responsible for maintenance. Although not if they start, they are only maintain the neuropathic or visceral or central neuropathic pain. And these are the mainly serotonergic, but also non-adrenergic, non-serotonergic. This is the adrenergic neuron is there. They provide the direct, they provide the direct descending pathway also by other dorsolateral pons. Other than this, directly rostral ventromedial medulla to spinal cord, there are the dorsolateral pons. It is by the way of noradrenergic releasing. This also inhibit the spinal cord. So here noradrenergic and the serotonin all are inhibit the pain pathway at the level of dorsal horn. In the higher processing center at the thalamus, there are the ventral posterolateral thalamus. This term sometimes comes in the MCQ. Which part of thalamus? Ventral posterolateral thalamus is the principal relay station of providing site specific information, and this they sends the information to the somatosensory area 1 and 2. So thalamus, somatosensory area 1 and 2 are known as the somatosensory processing region. In the anterior cingulate cortex involved for the emotional, that is the interpretation, the emotional significance of the pain pathway. And the lentiform nucleus and the cerebellum, the reflex response. When we have to remove our leg, our hand from the burning, when this is burning, there's something pin prick. When we will remove our hand from that side, so our lentiform nucleus and cerebellum act that way. Next come the insula, cerebellum, and the frontal cortex that may contribute to the memory and the learning of the event of the painful stimuli, so that we don't try to catch any sharp object next time. That is the avoidance behavior. So insula, cerebellum, or frontal cortex are the learning of the event of the painful stimulation. Okay. Good morning. Thank you. Do you have any question, please?
Thank you, Dr. Samir. It was a
Yes,
very wonderful description of the anatomy of pain pathways.
this is
Now,
just
I request our postgraduates to just ask any questions, or they can just
if they want, we can this video recording is there, na? This will be
yeah, we have recorded this video.
sir.
So now,
So
PGs, if you are having any doubts, you can just ask for clarification. I hope the presentation has made your knowledge about understanding about the pain pathway so clear that you can represent the same images and
because
wordings
this
in the exams. These are
pain
the
pathway,
very frequent exam questions in your DNB final theory paper.
because we always prescribe so many medicine in our pain day-to-day practice. We don't know what medicine, what is the nociceptive pain, what is the neuropathic pain, what is acute, chronic. I gradually want to cover this thing so that they can understand basic, and they will treat chronic. They can manage chronic pain also in their side by side anesthesia practice. So they will become more experienced. This will be our motto.
Exactly. So without understanding the pain pathways, the random prescription of pain medicine drugs will not give the expected outcome for the patient. So as anesthesiologists and pain specialists, we must understand the basics of anatomy and physiology. Then only we can use the pharmacology appropriately so that we can convert pathology back to physiology. That's the basic idea of our pain medicine. Okay. So I hope this session has delivered the intended result for the postgraduates, and we do have the recording of the session, and I will upload it in our YouTube channel also for the benefit of those who have missed this session due to some reason. So we'll be carrying on with such sessions in the future, and we sincerely thank our colleague Dr. Samir Basak, who has taken so much pains to create a wonderful PowerPoint presentation and deliver this beautiful lecture early in the morning.
Sir, in the next time, I will give talk about the essential pain management. This is the basic for all the doctor, all the paramedical person, all this is actually started by the New Zealand society, NAJCA. They actually they and Australian society, both in combinedly, they all over the world they started. This is the basic pain medicine course. This is the EPM, essential pain management. So next time, if we talk about the essential pain management, so that in this detailed, there is also online course. Any doctor, any paramedical person at any time can join and do the course by essential pain management, and they will immediately get the certificate of EPM. Okay, next time I will cover the EPM, so that they can treat the patient. They can treat the patient adequately by knowing the basic essential pain management, and after that they can go for online exam. There is a 60-minute exam, EPM. Okay, sir.
Okay. Okay, thank you. If there are no questions, shall we sign off this meeting?
Yes.
Yeah. Thank you once again, Dr. Samir Basak, for your very interesting and elaborate presentation of anatomy and physiology of basics of pain pathway. And we hope to meet again next month. Till then, thank you. Thank you, dear students.
Thank you, sir. Thank you all. Okay, bye bye.